This is Residents in a Room, an official podcast of the American Society of Anesthesiologists, where we go behind the scenes to explore the world from the point of view of anesthesiology residents.
Everything I do has an outcome that I can see and it's palpable, but also everything you do has an opportunity to have huge impact.
Critical care is a team game. So think about developing relationships outside of your family of anesthesiologists and intensivists.
Our schedule is actually fantastic in some ways, and if not better than what it would be if I was just a general anesthesiologist.
Welcome to Residents in a Room, the podcast for residents by residents. I am Santa Cruz Mercado, a CA2 anesthesia resident coming from Boston. I am currently enrolled at Bethesda Hospital. And today, the topic of this episode is going to be critical care medicine. We have two amazing guests, Dr. Megan Hicks and Dr. Ashish Khanna. They're going to talk to us about what it's like to practice critical care anesthesiology and what training looks like. So let's get started. Can you each tell our listeners a little bit about yourselves and your roles?
Sure. My name is Megan Hicks. I am a cardiac and critical care anesthesiologist. I did residency throughout North Carolina and then fellowships at Vanderbilt, and then came back to Wake Forest as faculty. I am an assistant program director for our critical care medicine fellowship and also am a developing researcher thanks to Dr. Khanna's mentorship. I have a focus on continuous glucose monitoring and wearable devices in patients having cardiac surgery, which fits in the kind of the niche of what my specialty is.
And for me, I came here from Cleveland Clinic, where I did my anesthesia residency and fellowship in critical care. I was on faculty there for a little bit before I came here. Been at Wake Forest now about 6 going on 7 years, and currently professor and vice chair of research with the department. And I'm a colleague of Dr. Hicks. I cross paths with her in our cardiac surgery ICU and our mixed med surg ICU. And I also practice general anesthesia. And obviously, it's great to be on the podcast today to talk to you, because it takes me back when I was thinking through these career choices myself.
Amazing. Thank you both for coming and talking to us today. I just want to highlight that it's really neat that we have also a mentor and a mentee, both who are now practicing. I think that the questions that we're going to ask you are going to be interesting for anyone listening. The first question I wanted to ask you is, why did you choose critical care?
My story is maybe a little unconventional. I did my medical school and first anesthesia residency in India. And in that part of the world, anesthesia and critical care go hand in hand. In fact, nearly 100% of all ICUs are run by anesthesia-trained intensivists. So my reason to go into anesthesia was to do critical care. And I will say that I was lucky that when I came to Cleveland Clinic to do residency number 2 in anesthesia, I was exposed to a very strong system of teaching, mentorship, and research in critical care and anesthesia. And our ICUs were heavily staffed by very focused, very motivated intensivists, all of whom were anesthesiologists. So I had a great first exposure in the United States, and that sort of intensified my resolve that residency number 2 and fellowship number 2 would still be critical care. And I would still choose to practice as an intensivist. And I've been doing that for the last 10 years now. So that's my short story.
This is much more interesting than mine. So I was a very traditional applicant. I said when I was 7, I was going to be a doctor. And here I am a number of years later. And when I went into medical school, I thought I was going to be an emergency physician. I had done training in EMS and been working in that and continued to work in that and through half of medical school. And I just love the kind of critical nature, the rapid resuscitation, rapid assessment, rapid relationship building with patients. And so when I started shadowing and going through my clinical rotations, I really liked everything. But I missed the being really, truly hands-on with my patients and doing procedures on the regular. And so when I kind of stumbled into anesthesiology, I was not a big fan of it. because getting up at 5 a.m. was not really the thing that I wanted to do. I am not the definition of a morning person, but I just absolutely fell in love with the mechanics of the job, how hands-on and how much immediate gratification we get in the job. But when I realized, kind of as I was committed to anesthesia and thinking about what I wanted my career to look like, that I didn't always feel like a doctor. I'm not a person who thrives necessarily on social interaction. I'm actually very much an introvert. And so talking to people all day was exhausting to me. And that's where it was nice to have my patients be mostly asleep. But I missed the family interactions, the patient interactions, and the more comprehensive care, to not just one patient at a time, which is what anesthesiology is amazing for. And so kind of exploring options, I really kind of fell into the ICU and just absolutely loved it. Instead of being haunted by the chimes and the alarms and things, I just thrive in that environment. And I get to fulfill that feeling of being someone's doctor and helping to interact with their families and make those close relationships, albeit in the short term, while still maintaining the immediate gratification. And then as I fell in love with the ICU, the place I loved the most was the cardiovascular ICU and patients who had CT surgery. And the place I loved in the OR the most, largely for the teamwork dynamic and just the kind of amazing dance that is a cardiac surgical case. I fell in love with cardiac anesthesia. And all three of those things together, so anesthesia, cardiac anesthesia, and then critical care medicine, kind of made this just perfect dream world for me of taking care of patients exactly how I wanted to care for them and in all the settings that I love the most. And so that is why I ended up in it, and I've absolutely loved it and would not have picked any other pathway, even on nights like last night where I was in the hospital till midnight with two very, very sick bleeding patients. That was, exhausting, but also just absolutely thrilling.
Great. Thank you for sharing your stories. I think a lot of people will be able to relate to both paths, both Dr. Khanna, your unconventional path, which I can relate to as well. But Dr. Hicks, also fulfilling your dream. I can't imagine, how your 7-year-old self sees you every day and things, it must be amazing. So if I could ask you, how has your experience been of being a critical care anesthesiologist and like with regards to what you expected? And then what has surprised you along the way?
Megan sort of summarized some of my thoughts in our last answer by saying, fulfillment, gratitude, a more of a holistic, I am in charge of everything. And I mean everything to that family during their most difficult time. And I think those things have pretty much defined practice, right? Both Megan and I have worked through sickest patients, both in cardiac and non-cardiac surgery in the ICU and in the medical world and in COVID times, for example, right? And when a patient is critically ill in the ICU, that family is looking at the intensivist as that one person who is not just managing care, but also managing to piece together a complicated story and present it to the family in a manner that's digestible, understandable, and helps them take the right decisions for their loved ones. So even though, you are on service for a week and off service for a week and on service, you are still, for that week on service, pretty much everything that a family can think about as they come into an ICU and leave the ICU. And that for me has been extremely fulfilling and gratifying, despite the tough days and long nights and weekends and holidays and so on. So in short, I think the journey has been great. I would obviously give a very biased comment in saying that a good intensivist who does also practice anesthesia also practices very smart anesthesia, because your grasp of cardiovascular physiology and resuscitation and what you can do to a patient, your ability to take all of those critical care skills to the operating room makes a huge difference in what is being done in the operating room. Those are just some of my thoughts there.
Yeah, so Dr. Khanna really actually summarized a lot of the things that have been most surprising to me. As he kind of hinted, the interplay between our expertise in the operating room and the ICU is unique. I am a better anesthesiologist for being an intensivist and vice versa. And I think that's because I understand what the long-term scope is for people having surgery. I think of patients in terms of their entire perioperative care and not just the operating room. And that makes me better in that setting. as well as having a true understanding of what they have just gone through physiologically in the operating room and what I'm seeing on the other side when they land in the ICU. I think the other part that has been surprising to me is just the respect for us as a specialty when people really understand what we do. I knew that there was something special about an anesthesiology intensivist because those were the people that really inspired me to kind of go into this field. And I just knew that those were the ones who were the rock stars, that when it's going down in the operating room and someone is crashing, that is the person I wanted by my side or as my attending. But I have started to notice that as, people are becoming more accustomed to what anesthesia critical care is, because I would say the general public don't realize that there are anesthesia intensivists, is the respect for who we are from the surgical standpoint. They're the ones that say, oh, I'm so glad that you're on service, or I'm so glad you're in our operating room because this one could get messy. And that's a huge compliment, right, to all of the training and the sacrifices that we've made to get to this point. And I think that that's a huge, huge thing for me. Not that I need the ego or the appreciation, but it's nice to feel that all of the hard work is respected and appreciated.
Thank you for that. I completely understand from the mentee's point of view and looking up to you guys, that was one of the reasons that attracted me. I can think of the people that I wanted to emulate the most. And to me, they were, like mind ninjas, and they were all ICU physicians and anesthesiologists. Those are the people that I naturally gravitated towards. And what do they have in common? And most of them were either cardiac ICU or ICU anesthesiologists. So I can see why you say that, Dr. Hicks. So there are a lot of myths out there or misunderstandings about critical care, especially because there's different training and different types of physicians that can be in critical care. Is there anything in particular that you would like to debunk?
I think the one that comes to mind for me is when I talk to, trainees about why or why not critical care, a lot of them say, it's just so sad. You have so many people dying all the time.
Mm-hmm.
And my response to that is it's changed over time, right? Because when I first went to the ICU and I lost my first patient, it was devastating. And it's still not easy to watch people die. But I think that the beauty of critical care is that we can provide people a peaceful, painless death with dignity if that is what is going to happen. And I think allowing us to be there in that most critical period of time, that like true crisis to the patient and family, as we have trained to take care of these patients, we also train to care for their families and to care for the experience as a whole. And sometimes that means that someone is dying, and the art of communicating that to a family and sometimes to a patient directly, because a lot of times our patients are intubated and sedated, but sometimes the dying patient is right awake and looking at you. Conveying that in this horrible time in a way that does not cause fear and does not cause distress and allows death to actually be peaceful instead of something traumatic is an incredible gift. And I find that to be one of the best parts of my job, as weird as that sounds. The death is not always the worst thing. And I think it's because we know how to facilitate it in a way that there's dignity for the patient, if you will.
Just to sort of piggyback or also give the other side of that is, yes, there is death, but then there is those that live to walk away from the ICU and they come back to meet you afterwards. I think that adrenaline rush of actually saving them initially and then to see them come back, a lot of patients will come back to meet us, very quickly provide that story of that 18-year-old boy who had like a BMI of 73 during early days of COVID and the pre-vaccination era, who we put on VV ECMO one night when I was on service, and how 4 months later, he walked away from the ICU, walked away to a better, and fully functional life, and actually came back to meet us. And I think it was extremely gratifying for not just me, but the entire ICU team to see it. And those stories you remember for life. And this is just obviously a really grandiose fairy tale, but there's those you save with septic shock. There's those who you save will come in that are acutely bleeding. There are those that the COPD exacerbation. So there are those stories. So I think trainees should realize that, yes, as Dr. Hicks says, there is death, but you are there to help families deal with death. But there's those saves also where you're the hero. And then the other fear and misconception I want to dispel is when I talk to trainees, I also get a lot of this, oh, if I do critical care, it'll take me away from anesthesia. And I don't know if I'll be a good, anesthesiologist again. I won't be able to do this or that. And then finally, it's like, oh, I won't get my favorite private practice job. So there's a few things to dispel there. Number one, both Dr. Hicks and I we go to the operating room, and we still call ourselves as anesthesiologists, and we have no problems doing anesthesia. Number two, there are 100% private practice jobs very much available, especially in the last 5 years or so. I've seen them grow, where anesthesia critical care is a service that you provide to a private practice group. So you have to look around, you have to know the right people, and you will find your favorite job. So you're not just restricted to the world of academia.
Thank you. And thank you for bringing those important points. You both have kind of touched upon the question that I wanted to ask you next, which is, in your opinion, and what are the barriers stopping residents from choosing critical care? And what are the things you think we can do to break down those barriers?
Like you said, I think we've covered a lot of the different barriers, but I think, especially in this anesthesia market, right, there is an opportunity cost to doing a fellowship.
Yes.
Because, there's competitive pay and you're sacrificing that to take a year to extend your training. But as we've talked about, I think that training is worthwhile and it makes you better at both sides of your job. I think that also people think of our job as just pure insanity and that I'm working all the time. And so I think it's just really interfacing with residents more and interfacing with intensivists directly with residents or even earlier trainees as medical students to show them what our life is really like, that we're real humans, that, yeah, we're ninjas in the operating room, but we're also, moms and people with hobbies and things like that outside of the operating room. I think that's the biggest thing, to let people really see the reality instead of this fabricated impression of what the intensivist life is.
Yeah, and I think Megan has put it really nicely there. I think there is a lot of balancing in terms of work, life, and more work and more life or whatever you want to do. But I think the motivation and the desire to be in the thick of things will mostly supersede all of these other things as noise. Yes, all of are humans and we do need our time off as well. But there is a whole lot of flexibility built into this job that wouldn't have happened if I was not practicing critical care.
Great. And when I think about my, co-residents and other people I've heard talk about the ICU, they usually think about their long calls or IQ3 call, in the SICU, and can't imagine doing that forever. And I can't imagine doing that forever either. But it's because I think often we forget that that's a short period of time during residency, during training, but after training, things are a little bit different. So Dr. Hicks, I know you're a mom with a new baby. Congratulations.
Thank you.
And I believe both of you are parents.
I'm a parent of 3 children, so I'm one ahead of Megan. So anyway.
Yeah, he is. His life is harder.
And I mean, critical care can be a difficult path. Like you said, Dr. Hicks, people are taking that 1 year off where they're kind of taking a cut in making money after a long period of not making very much during training. But also time-wise, how do you make that work? Having 3 children on Khanna or a young baby at home. Can you talk about the daily life and your schedule and how you practice?
I remember how tired I was when I was a resident in the ICU for a full month. And I think one of the things that's important to remember is I'm only doing a week at a time as the attending. So right. Yes, a month is exhausting, and it would be for me if you told me I had to do a month in the ICU, but that's not what real life looks like. So now at my longest, I'm doing 7 days in the ICU. And yes, those are long days, but they're actually nicer than an anesthesia day sometimes because they're a shift. I know when my relief is coming. Someone is showing up at 5 o'clock, and unless there's an emergency, I'm leaving after I hand off care. And so the predictability of that is actually a better week for my family than the OR days when I'm, hey, I could be home anywhere between 3 and 5, 7, depends on whether it's full or not.
Yeah.
And so that predictability for childcare and things like that makes it work. I also think that people forget that we get post-call time. So whereas in residency, you may not get a week off after you've done a week in the ICU. In fact, you will never get that in any residency program. If you let me know where that was.
I was about to ask you where
exactly. If you found that. But a lot of jobs provide 1-to-1 or, at least several days in a row off after you've done a long stretch in the ICU. And so our job, we're fortunate enough that it's basically a 1-to-1 ratio. If I work 7 days, I get 7 days off. And so, yes, I have a busy week where I don't see my kids as much for 7 days, but then I have 7 days where I'm off free of clinical and theoretically non-clinical duties, which often, I know Dr. Khanna and I will both tell you, we use that time productively, especially when my kids are at daycare and I have nothing else to do other than catch up on life. But that I think is a huge luxury. I get to see my kids all the time on post-call days. And so it is a give and a take, and it's a balance. I am very lucky, and I can say this about Dr. Khanna's wife as well. We are married to incredible partners who both actually have careers as well, which is not always the case. And they are very demanding careers. Mine's an attorney and his is a physician. And we make it work because we work as teams. We also have built our communities, right? I have some family, but unfortunately don't have as much as I'd like. And I know Dr. Khanna doesn't have a lot of family around. And so we hire help. We have made a network of people that we look to and depend upon to care for our children. That includes an incredible daycare. Yes, that's an expense, but it's one of the best expenses I make to make work. Yes, do I have a house cleaner? Absolutely. I have somebody who helps do the deep clean on my house so that I can spend that time with my kids instead. And I'll outsource some things, and the cost and return ratio is huge because it just is about time. And so a lot of it is just about planning and having the right person on your team as a spouse. But I know some single parents by choice that are also thriving in this world. And I think the schedule is wonderful in the way that it can be built and facilitated and used to actually make it a very family-friendly job. And I think that the ICU part of my job is more family-friendly than the anesthesia part sometimes.
And Laura, as you can see in the true spirit of, again, the mentor-mentee relationship, the mentee.
Yeah.
I was supposed to thank my wife on air and then have her listen to the podcast. But again, Megan has already thanked her. So I thank again my wife and our full-time nanny who lives with us. It actually has been for the last 11 years. So I will say that it takes a village, and it truly takes a village, right? And just add a slightly different tangent to what Megan just said. What I tell trainees at your stage of their career, Laura, is they have to think of a specialty and then have to think about, number one, when they go to bed at night, they're happy with what they're doing and what they have chosen to do. So even after a long ICU day, you might come home and, vent with your spouse for like 2 minutes, as long as your spouse is okay hearing you venting. Or with a colleague, or went somewhere, but you're still happy. You're still happy, despite the fact that you did went and say, "Oh man, that patient just drove me nuts today," but you're happy. And number two, and I'll put on my research hat here and say, if you are also the kind of person who can bring science in and have some sort of question that is driving work, right? And building a parallel career, whether it be with research or innovation or teaching or something else, right? Building that parallel career, then it also brings more happiness and joy to whatever specialty you choose, but also specifically critical care, because critical care then opens you up to that whole world, which is sort of the non-anesthesia side of things. The people who deal with septic shock and resuscitation and vasopressors and the perioperative world, right? It has opened a whole different world to you, which you wouldn't have normally been exposed to. So think about also, not just coming to work and going home every day, but also developing those questions that can advance you in that direction.
Amazing. I want to start with thanking my husband before we are at the end of the episode, to make sure that he knows I've acknowledged them too. But I completely understand not being from this country, and you do need a village to get through it. But as you were talking, I was just thinking about how I am post-call right now, and I'm smiling. I'm really happy to have this conversation with you. And, even though I'm exhausted, and I have to be in really early tomorrow to take care of my patients. I don't.
Let me say this: you're all set. You're all set for a future.
Mhm.
So,
Yep.
Oh, thank you, thank you. I mean, I feel I am very happy, just like you said, right? If I had to ask myself that question right now, I wouldn't do anything else, even though I'm exhausted and I'm a trainee and I don't love the 24s. But also going back to what both of you have talked about, and something that was very appealing to me, and I think something that kind of like, again, I didn't realize up front, but it's become very evident to me, is the opportunity to continue to grow in so many aspects. Just that environment that is, the intensive care unit. I feel like it pushes you to continuous growth. Um, do you want to talk a little bit about the non-clinical aspects of critical care and what kind of research or educational opportunities exist in critical care? I know you've kind of touched upon it, but if you want to elaborate a little bit more.
The mentee is going to defer to the mentor.
I'll keep it short, but I'll just say that you have to, as you do your fellowship, either develop a liking for a certain aspect of critical care where you want to ask a certain question, or you have to have a chance happen to you where you stumble across a mentor and you like what the mentor is doing and you latch on to that. But I often tell trainees that it's important to find a niche and find it relatively early, and then don't give up on it. Your first few papers that you publish should define your next 50 papers. And the way that will happen is that you, as soon as you see that this is your happy place where you have the support, you have a system around you, you have a mentor, you have a place where you can do research, then you keep going. The opportunities, obviously, I can spend hours talking about, the specifics of opportunities, but what I'll specifically want to touch on is, like in my career, it was FAIR, the Foundation for Anesthesia Education Research. They're a great starting point for early career grads. There's also other mechanisms through the NIH, but I highly recommend both FAIR and IARS, but specifically FAIR. FAIR really does a great job in following you for life. When you are a FAIR awardee, there's someone who's watching you all the way through your career and taking pride in the fact that you are advancing. So I want the trainees to think about FAIR. And then the other thing I'd want the trainees to think about is that critical care is a team game. So when you think about doing research in critical care, think about developing relationships outside of your family of anesthesiologists and intensivists. Think about going to what Dr. Hicks is doing, working with an endocrinologist, or think about like I do. I work with a whole lot of medical ICU doctors, for example, in the world of sepsis research. I work with pulmonologists. I work with physicians in my world of wireless wearable monitoring outside the ICU. That, again, is a huge opportunity. It opens up all of those avenues that those other specialists are also going to have in their field. So that in a nutshell is opportunities, although I will tell you, you can do a whole podcast about it.
Yeah. And to elaborate a little bit on that, there's clearly tons of research opportunities, but the non-clinical parts of my job include not only research, but also, like I talked about, education, as well as kind of administrative jobs. So there's a decent number of, people with MHAs and MBAs that are also physicians that are really working on, hospital and departmental administration. And I think that is one avenue that's absolutely, great to pursue. But even as a more clinically oriented person, I'm a medical director of an ICU. And that really is a big part of my job as well. And so, you can do research, but if that's not your thing, you can still thrive both in academics and not in academics, and do things that are kind of clinical adjacent, but that really expand the experience and the diversity of my job. No day looks the same, which we say in anesthesia a lot, but that's ever more true as a faculty member now.
Great. And I just wanted to ask you one more question. We've talked about many different aspects, the research, the educational aspect, what it's like to be an ICU physician now. But if you can think back to your years in training and also now as mentors and of new trainees, could you tell us a little bit more about what should our listeners and might expect from a fellowship in critical care?
So the Anesthesia Critical Care Fellowship pathway is a 1-year fellowship, just like all anesthesia fellowships. And in that year, you're required to do 9 months of critical care. And so that is in predominantly surgical ICU. So it's not kind of the nightmares that I still have back to my MICU days as an intern of taking care of, those just multi-system organ failures. It's people who are actually going to bounce back a little bit more quickly because oftentimes their only issue is what they've had their surgical procedure for, with the caveat of the, cardiac population who have every comorbidity. But it is, it's an intense 9 months. It's an intense year. I had elective time in both other ICUs. So I did some time in a burn unit and a VA SICU, which is a totally different population. And then we also had lots of echo integrated into my fellowship. And there are fellowships in this country that actually allow you to get a perioperative echo certification. And different fellowships have different focuses, and there's also different fellow experiences. There's programs that really depend on their fellows for the hospital workforce, that when there's a fellow missing, the staffing falls apart. And then there's also ones where fellows are sometimes in more of an observership role. They're not as directly integrated into the staffing. And so there's huge variation across the country, but the end goal of all of those fellowships is that you come out able to care for a patient in any ICU in any setting. And I feel like that certainly was the case for me. So yeah, it was a tough year, but it was a year that, again, made me a better doctor as an anesthesiologist and an intensivist. And I would describe it as actually the best year of any of my training, and just thought it was wonderful. Not that I have any bias towards Vanderbilt at all, but it was amazing.
Yeah, and Megan summarized it well, and I think it would be wrong for us to say that it's a easy fellowship. You're going to have a lot of downtime, et cetera, et cetera. And honestly, you would not want your fellowship to be that. I mean, that's a 1 year of your life where you're going to have the opportunity to learn and train. So you want your critical care fellowship to be adequately busy and have adequate exposure and have you involved as a fellow, right? So you have to be careful that you're not trying to grade your fellowships based on, how much post-course time do I have? Listen, it's only 1 year of your life. It will end. You have to realize that you're always served in better fellowships where you are, as Megan just said, part of the decision-making team. And in fact, as you become more senior as a fellow, you should be functioning as a independent intensivist, learning to round with multidisciplinary teams and controlling the workflow in the ICU, which in critical care is almost as important or more important than the whole practice of critical care medicine. And that you have to be exposed to as you're finishing fellowship.
Yeah, completely agree. So we're going to flip the script a little. And Dr. Santa Cruz Mercado, we want to ask you a question. And that is, you're interested in doing critical care. Obviously, we got you to drink the Kool-Aid, but can you tell us what draws you to the subspecialty? What makes you say, yeah, I want to be an anesthesiology trained intensivist?
Yes. I thought about this question a lot going through interviews, but even before that, I realized during med school, I thought that I was going to be a surgeon. Like many of us, I was influenced by social media and shows like Grey's Anatomy, where it looks like, the surgeon is the coolest physician and the night savior. Not that our colleagues are not amazing, but that was my idea going into medical school. And then one day, like you said, Dr. Hicks, I kind of stumbled upon anesthesia. My first experience with anesthesia was, 3,800 meters over sea level in Bolivia, my home country, at a pediatric hospital, and where we have very limited resources. I saw the anesthesiologist who was going to take care of this little baby who was going to have open heart surgery, one of the first ones in the country, because they usually don't do well preoperatively, given, the altitude and the low resources. But I saw a very human side of this physician, and it felt like I was looking at a ninja and a hero and someone I wanted to be. I saw not only the amazing expertise and the seamless transition from the OR to the intensive care, but how that physician was able to provide support and reassurance to those parents. I remember the look of the parents, giving their baby away, into her hands. And that was a huge impact to me. So I knew anesthesiology was something for me. The cardiac OR. I also, like you said, I've drank the Kool-Aid. It felt like I was in an amazing, almost like experiment, because I see everything I do has an outcome that I can see and it's palpable, but also everything you do has an opportunity to have huge impact. And then without realizing, I had collected a bouquet of mentors. My mom had read a book and she had told me that in life, to be successful, we should have a bouquet of mentors of all walks of life. And I kind of collected from different walks of life. With regards to medicine, I realized that all of them, or most of them, 90% of them, were ICU physicians, anesthesiologists, and a couple of them also cardiac intensivists. And a lot to what drew me to them as well was the way they thought about things. So I could see, this is where I call them the mind ninjas, the ability to look at problems and look at people, humans in medicine, and just practice so seamlessly. And Dr. Khanna kind of also alluded to the not only multidisciplinary environment, but the interdisciplinary environment. I really believe there's an art. You need something more than just, the practice of medicine to be able to really manage an intensive care where everyone is, yes, working for the patient, but you're coming from such a different backgrounds, and everyone it's looking at everything from their own view. So that was something that was very attractive to me. I knew that in an intensive care unit, I would be pushed to always want to be better. Also, going back to the emotional component, I felt like just like in anesthesia, I would have the opportunity to make huge impact. Most of the time when we meet our patients at pre-op, we forget that it's for them maybe the scariest day of their life. And in intensive care unit, that is for sure the case. And when you meet those families, but that means even smaller actions have huge impacts. And just like you mentioned, Dr. Hicks, I realized that we have the opportunity to help people also transition into a period that, death is not easy. And for sure for me, I still need a lot of training, but I've seen how amazing my mentors have been at being supporting great physicians, but also just amazing humans for those families and for those patients. And if God forbid ever anything happened to me or my family, I would hope that I would have someone like that and, on our team. So not to make it any longer, so many reasons, but you can see I've really drank the Kool-Aid. I just feel like I found my tribe once I entered the ICU.
It's really good Kool-Aid.
I agree.
So obviously, it looks like you're not changing your mind and you're going to stay focused on critical care. Is there anything that would happen in this next coming year that would make you less or more interested in critical care?
That's right. I'm not changing my mind. I'm hoping to find out where I match in the next week. But I've had many friends in residency that are really they might like the environment, but they really don't know. And a lot of what has come up is really the fact that these are difficult times and things are getting more expensive and people have families. And, taking that year off, for me right now, it looks like an investment, just like you've talked about it. But sometimes for people, it's hard to see that. And I understand it. Their situations are different too. So I think that's been something that has repeatedly come up when I've talked to my friends. And I think also another thing is kind of what you debunked earlier, which is the schedule. I think a lot of people are not aware that the schedule is actually better. I was very lucky to have mentors that I could talk to, and thinking about planning a family and in the next few years, and how being an ICU physician would allow me to have a little bit more time, like you said, Dr. Hicks, to go through that period of time without having a lot of support here in the US, whereas just my husband and me, which, the ICU would allow me to do that, as opposed to if I was just doing the OR, it'd be a little bit more difficult. So again, those are things that I was blessed to have the opportunity to talk to a mentor and get answers. I hope that people, just get to listen and then hear you, Dr. Khanna and Dr. Hicks as mentors and debunk those myths. And hopefully they can ask more questions and just reach people near them to see if maybe this is the right path for them.
Thank you, Laura. I just wanted to add one thing that Megan and I didn't say, but I want to encourage you and others to also think about societies like the ASA and the ASA Committee on Critical Care Medicine and the Society of Critical Care Anesthesiologists and the SCCM, where you will find like-minded individuals going through similar stages in life, making similar career choices. So find that tribe outside of work. For me, that has been a great way to sort of survive through tough times, right? Thank you so much for doing this podcast for us today. I really enjoyed it. Thank you.
Well, thank you so much to both of you for sharing your expertise with me and our audience today. You've given us all a lot to think about. Thank you for your very honest answers and your advice. And to our listeners, we appreciate you tuning in to Residents in a Room, the podcast for residents by residents. Join us next month for another episode.
Find a near-peer mentor that can give you guidance and support as you navigate the early days of your career. The ASA Mentoring Program provides an on-demand mentoring relationship so you achieve your personal and professional goals. Sign up today at asahq.org/mentorship. Join us for Residents in a Room, where we'll share timely info, advice, and resources designed to help residents succeed in residency and beyond. Find us wherever you get your podcasts or visit asahq.org/podcasts for more.